Hello everyone, myself Dr. Mohid, and today we'll be talking about the cutaneous fungal infections. Alright, so even as a previous topic, right, about the contact dermatitis, even this topic I think is pretty common. Yes, even the disease in this we will be seeing, right, it's pretty common. We see all the tinea infections, but now we will just break it down completely, the whole cutaneous part, yes, and the superficial one, the cutaneous and the subcutaneous part, and we will be seeing all the examples, and we'll be reading about them in detail. Alright, so with that, let us start. First of all, I want to get the classification right of fungal infections. Okay, this classification is based on the extent to which the fungus is been breaching the skin. Alright, as simple as that. Keep that one point in mind. So first of all, we would have a superficial fungal infection. Yes, the next one would be a cutaneous one. The next is subcutaneous one. Okay, all right, and in that we'll be reading about particular examples. Yes, that is important. So, and even this topic, right, it is going to be a very huge overlap. I guess 90% overlap is from microbiology. Yes, so if you have done your microbiology, right, this would be a very easy revision for you. If not, I have included all the points in it from microbiology so that we can integrate everything very well. All right, so let us begin. The first one is the superficial one. Yes, one question to you guys. If I say superficial, right, what is the uppermost superficial layer of the skin? Simple. Yes, you think on that. Meanwhile, I'll just mention the superficial parts, that is the epidermis and the dermis. Okay, so the answer was stratum corneum, right, which is stated on the second line right here. But the thing that is very interesting over here is, because if we know this one point, we can clearly elicit the clinical findings of this patient. Do you think in stratum corneum, so if you guys remember the example, the thing we discussed in our introduction, right? So how did we learn the whole thing, that big smart guys love coffee, right? The coffee was stratum corneum. Yes, so if it is stratum corneum, right, it is the most outermost layer. Do you think were there nerves or not in the stratum corneum? There were no nerves, right, because stratum basale is the one, or stratum germinativum is the one where there was proliferation of the keratinocytes, and eventually the cells would dry up and become denucleated, and at the top we would have the stratum corneum layer, right? As simple as that. Yes, if it does not has any nerve supply, do you think the patient would have any, like, too much pruritus or something like that? Yes, some findings would be there, but moreover there will not be too much of pruritus in the patient. All right, so because why the patient doesn't have this is because the fungus is only invading the stratum corneum. All right, so now I hope whenever we read tinea infections, specifically Tinea Versicolor or another one, this one point comes to your head and everything is very crystal clear, right? Okay, over here we have the stratum corneum. Yes, and the point we just discussed, that it is a dead layer, right? And hence, because of that, you see the patient would be asymptomatic. Pretty much, if you have seen the videos, right, some patients, they have this Tinea Versicolor infections, they're comfortable with it. Yes, they probably only visually they would find, okay, fine, I'm having this these patches, what is that, there could be that, but their main complaint would be the hypopigmented patches, not the pruritus. Okay, so I hope I'm making myself very clear here, because as we go we read about Tinea Versicolor, right, and over there we are going to write the finding as pruritus, but the patient will not come with pruritus. He will come with okay, doctor, I am having these patches, what is this? So one question to you over here that I will not answer here, but when we start our topic, I want your head to be oriented in that question answer fashion. What do you think are, how do you think are the patches of tinea of this Tinea Versicolor? Alright, how do you think are the patches? Are they hyperpigmented or hypopigmented? We will come back to that, okay, and we will discuss this one topic very detailedly. Okay, fine. So coming on to our discussions about the introduction of this chapter. Yes, we have a few examples waiting for us, that is versicolor, 𝗵𝗵 infections and Tinea nigra. So these are just one of the 3 examples that I have listed over here. The list is quite huge, but these are the important ones. So coming to the next one, that is the cutaneous infection, right? The cutaneous part. We just got done with the superficial, now we are at the cutaneous one. In the cutaneous one, what do you think it could affect? It could affect the deep epidermis, and the dermis. Okay, alright, so just coming on to the same thought that we just discussed in the previous topic, right? So if it is just superficial part, the patient was asymptomatic, yes. So do you think because the deep dermis is involved, yes, do you think the patient is going to be symptomatic or not? Yes. So I hope you are answering symptomatic, and the answer is symptomatic. The patient would have a lot of itching in this condition. Okay, so the patient will be symptomatic. That is, he or she would have a lot of itching, would be there. Okay, fine. What are the examples that we have over here? We have the dermatophytes, right? Even in the dermatophytes, we have the 3 brothers, yes, a Microsporum, Trichophyton and Epidermophyton, yes. There's a very beautiful table that and I'll also tell you how to remember that, yes. So you will 100% never get any question wrong related to the manifestations of these 3 dermatophytes. Okay, everything is just waiting for us down the lecture. And the next one is the Candida. Even in Candida, we have 6 types of Candida, right? It is not just that oral thrush image we see everywhere, right? So it's not just that, there is more in Candida as well. Okay, coming on to the next one, right? We have the subcutaneous infection. In subcutaneous infection over here, definitely, because it is the epidermis is involved, the dermis is involved, now it is subcutaneous tissue which is getting involved. Yes, over here we have chromoblastomycosis, and there are 2 more. I'll just mention it: chromoblastomycosis, and we have sporothrix. Any bells ringing in your head if about sporothrix? And we also have mycetoma. These 3 topics, I feel they are very important as far as microbiology is concerned, and definitely derma is also there. Yes, even dermatophytes, there's always question in dermatophytes, right? Because of that table, which is very confusing. They could either give us the microcornidia or microcornidia, or the findings, the hair findings, the nail findings, the skin findings. Something would be given, and we would be asked to make a diagnosis. Even the treatment for all of them are the same, but still, a good clinician, we would definitely know, right? What is the exact thing. Okay, all right. So let us continue our discussion about the cutaneous one. And first of all, we have the Candidiasis. Okay, all right. In Candidiasis, right? So first of all, we have Candida albicans. Yes. So one of the main things regarding this is it is a normal flora on the skin. Okay, but under favorable conditions, okay, for example, the pH is changing, yes, and that could be one reason that this organism turned pathogenic. okay. But in even in like a normal flora, right, okay, fine, but the patient won't be symptomatic, yes, because it is just a normal commensal on the skin, right, on the skin or on the mucosa, yes. But over here, what could be the predisposing factors? What do you think it could be predisposing factors? So I'm pretty sure there's one disease is coming on in our head, that is immunocompromised patients. It could be the HIV positive patients, right, in the later stages, that if the CD count is low, in that conditions we could see the very aggressive oral thrush. One question to you: do you think this oral thrush is it easily we can scrape it off or not? Yes, that is one question I want to ask you. And if yes, okay, fine. If not, then in which disease can we is the white plaque not easily been scratched off? All right, that is one question I want to ask you. Okay, so, and definitely we'll be discussing about this again. Yes. So the predisposing factor at the first point we discuss is the immunocompromised patients. Okay, all right. And the last one, I'm pretty sure if you can guess it, it would be very amazing. I would be very happy if that happens. Yes, definitely long-term use of oral steroids, that is one point, and even in moist conditions, yes. But the last one is the quite I would say interesting one, that is the ill-fitting dentures. Yes, probably definitely old people, right? Some the geriatric people, for some cause they lost a tooth, and now they have a new set of teeth. They have dentures, but if these dentures are not aligned properly with their oral cavity, that could lead to candidiasis. So what do you think? How will be the presentation of candidiasis? Either it could be white or red. Yes, there are two types of candidiasis. It's just not that white type. We'll be discussing further. And in this one we have the erythematous one, the red one. Okay, so let us just fill up our notes. That is the ill-fitting dentures. Alright, so we just got done with that. Yes, that is the candidiasis. And over here, we'll be keeping our discussion short. Yes, definitely there are a lot of more types in the, as we have discussed in our detailed series, that there are about 6 types of candidiasis that could be discussed, but just keeping the discussion to a very concise, limited ones. Okay, that is one thing. And in the ill-fitting dentures, we have the red one, the red plaque one. And in the immunocompromised patients, we have the white plaques. Okay, let me just mention that also. And over here we have the red plaques. Over here we have the white plaques. Okay, alright, so we just got done with our first cutaneous infection, that is the candidiasis. Okay, so what is the next one? Definitely, if you have the versicolor in mind, that is the right one. The versicolor, the one we discussed a bit too much in the introduction. Okay, maybe I got a bit more excited about the topic, nothing else. Okay, alright, so what could be the etiology, right? What is the one organism which we have in our head? Yes, so definitely it is the 𝗲𝗵𝗵𝗺, or it could be 𝗲𝗵𝗵𝗺. Yes, these two are the organisms which are responsible for that. Yes, and even in that, if we want to choose one, if both of these guys we see in our MCQ, we would go on to 𝗲𝗵𝗵𝗺. Okay, globosa, that is the most common one. Alright, so that is the answer to the first blank that we have here, that is the 𝗲𝗵𝗵𝗺, the two guys, right? 𝗲𝗵𝗵𝗺. Alright, definitely that is a normal inhabitant of the skin. Yes, a shift in the balance, right? That is the one who causes this, right? a shift in the balance. So just a personal advice, you know, to the viewers, that is, definitely we all are very concerned about our skin. We all want to have that nice, perfect, you know, perfect skin. So whatever products we use, we have to make sure that there is very less of acidic content. Yes, that is the reason these companies, you know, which we see a lot of people using them, if they have less acidic, the results are very good, and they won't, if they're not benefiting your skin, at least they won't damage you, right? That is one point that we can take it. Okay, how about the clinical features? You know, we can see over here comes the point which I asked you in the introduction, right? It is on the next slide. So the first, right, so the first, when the 𝗲𝗵𝗵𝗺 globosa, for example, it is on the skin, yes, and it just plans, okay, fine, I will just, you know, invade the skin more and more. So where do you think is the invasion is going to occur? So the invasion, do you think it's just gonna break the intact skin dermis, or it could just go on, probably affect the perifollicular areas, and from there on it could, you know, coalesce with each other, make a bigger patch, and then, you know, the doctor would see and it would be like, oh, okay, you have a hyperpigmented patch. Yes, yeah, if you're thinking the other way around, that is the right one. Okay, so that is what we can see in our image also, right? In a while we'll see that. So what it affects is the area around the hair follicles, yes, and it is a lipophilic fungus. Okay, it affects that, and because that is the reason, you know, in one patient I had seen that on his back, usually the patient presents that, okay, fine, we have these lesions on the back. He told me like, doctor, I'm having this very mild spots, you know, on the back. What do you think it could be? Even though the lesions were not that visually visible, right? When we gave the treatment, the patient responded pretty well. So in dermatology, a lot of things, you know, we just have to just guess and give the treatment, and then hopefully everything would be okay, because we cannot just prepare just a slide, right? Just write up, you know, for the patient. Just as a preliminary treatment we would give, and the patient response, all well and good. I hope you didn't answer we use topical steroids, because that would lead to another sort of conditions. Yes, in this we would use the antifungal emollients, that antifungal creams, we would use it. Alright, these are the perifollicular hypopigmentations. As you can see, the one which we discussed right now, that is the perifollicular hypopigmentation, and this is where the whole mayhem starts. Okay, alright, that is the answer to the blank right here. That is the perifollicular distribution would be the, we would see in the very initial stage. Alright, yes, and over here in the image, right, we can see this is the hypopigmented macules and patches. I hope you remember the table, you know what to say when we discuss one table. Yes, and yeah, there are the word, right, the word pityriasis. Yes, another word for this is Cutaneous Versicolor or Tinea Versicolor, right? So this word pityriasis means browny or scaly, right? That is what is elicited here, that scales are powdery, briny or scaly, right? Even though in the clinical finding we cannot elicit much of the scaly part, yes, but it is in a theoretical way. Okay, all right, so the question that I ask you, that would be a hypopigmented or a hyper or hypopigmented patch. Yes, so if you guys said hypopigmented patch, your answer is right. If you guys said hyperpigmented patch, your answer is also right. The answer is that both of the pigments are being seen in a patient. Yes, so a lot of us, we do make mistakes in the clinical findings. Yes, we just see that, okay, fine, if there is hyperpigmented patch, it's definitely the Cutaneous Versicolor or Tinea Versicolor, both are the same thing. Alright, so we could find both of these patches, either it could be hyper or hypo, as you can see in the image. If so, one question is very interesting question, right? So if there is a hypopigmented patch, so why do you think, you know, most of these patients we have hypopigmented patch? What do you think the reason could be? One of the thought that we could have, that, okay, fine, the fungus is doing something, you know, probably it is inhibiting something in our skin which is responsible for imparting the color, right? That could be the melanosome. Yes, over here the ingredient, the thing, right, which we have to answer is the azelaic acid, right? Azelaic acid is the one which inhibits the tyrosine production in the melanin production, right? It inhibits that. That is the reason we have this hypopigmented patches. Okay, so the answer is azelaic acid. So because of that, it inhibits the tyrosinase, yes, and it inhibits in all the melanin production. Yes, one point more I want to cover here is about the skin tanning of the skin, right? What do you think these patches? Do you think these patches would be easily tanned or it will not tan? What do you think? Because now you know why this is happening, right? Because of the azelaic acid, right? It is inhibiting the tyrosinase in the melanin production. That is the reason. Yes, it is all happening. So even after sun exposed, of even for a long duration of time, these areas will not get tanned. Okay, so because of this, the area won't be tanned. Okay, all right. So that is all about that one point related to tanning of the skin. Yes, and if there is hyperpigmentation, all right, if there is hyperpigmentation, so what would be the reason to that? Yes, the reason is pretty simple, that if there are abnormally large melanocytes, yes, that could be reason that the patient is having hyperpigmented patches. Okay, okay, all right. So let us just go on to, we see these images, right? Okay, so that is one thing we just saw over here. Initially, would you think this guy came or the small ones came? Yes, so these small patches, right, these were the ones who came first, the perifollicular ones, as we discussed before, and then they coalesce with each other, and then we have this bigger patch, right? Okay, all right. So this is an example for the hypopigmented one. This is another example where you see in a patient on the forehead we have these hypopigmented patches. Okay, and definitely this is very easily treatable, very wonderful results. Okay, and coming on to the last one, that is the hyperpigmented patches. As you can see, right, in the patient, yes, this is the normal skin, and right here if you see, this is a hyperpigmented patch. Okay, so just be aware, right, that in tinea infection it is not just the hypopigmented patch that we are just running towards. It could be hyperpigmented as well. Okay, all right. So coming on to the next one, that is the investigation part. What do you think and how do you think we should investigate this patient in case we have to do it? Okay, first of all, we would have something very delicious. Yes, this thing, right? We have nice spaghetti and we have good sauce in it, and definitely there are meatballs in it. Yes, okay, so that is one finding that we would find, yes, in our slides. Okay, that is one of it. Okay, so let's just come fill our notes and then we can describe more of this. Okay, so in a 𝗲𝗵𝗵 slide, if we prepare, we would have spaghetti and meatball appearance. This is a very extremely popular sentence, in the whole of microbiology, in the whole of derma, right? This spaghetti and meatball appearance. Okay, so please make sure if wherever, and even this one image we see, yes, this is the one which is like most commonly used image everywhere, right? Okay, all right, so let us just come fill in our thing, that is spaghetti and meatball. Alright, it is not meathead, it is meatball. Okay, alright, so in the Wood's lamp finding, in our introduction series we covered this topic, that in the wood lamp finding we made a whole list, right, in which color is there, and in this one, if you remember, we had a pale yellow color, right? One question to you, so which one had a coral red fluorescence? Yes, if you have this answer in your head, that is, it was because of what? Porphyrins, right? Erythema. In that conditions we have coral red appearance. Okay, and in Wood's lamp we would see pale yellow. And everything, these small things we learn, what happens is, because of these are the hot words that the examiner would use, probably in your viva, or probably in the MCQs or anywhere, because these words are the clear indication for that. Even though the examiner might try to confuse us, giving 2-3 links, but if you know these hot words, because this is a very clear cut finding, pale yellow, spaghetti and meatball, hyper or hypopigmented patches, if we know this, we cannot go wrong in our diagnosis. Alright, and that means everything to us. Okay, how would you go ahead with the treatment? Yes, so we would use the antifungals, right? We would use the azoles and terbinafine and selenium sulfide. Yes, one important point waiting for us in the third one, right? Okay, fine, we would use ketoconazole topically. It is a very fantastic drug. But would you use ketoconazole systemically? The answer is no, right? Why won't we use ketoconazole systemically? Is because ketoconazole has a side effect, that is, it is hepatotoxic. Alright, because it is hepatotoxic, we would not use it. Okay, and one more thing, that is the oral terbinafine and 𝗲𝗵𝗵, even though these are very fantastic drugs, they do not work. Okay, they do not work. Okay, all right, that is all for that. And over here at the end of this, right, I would just give you some limitless hot words. If you see in any MCQ, in any case presentation or any discussion, right, we would just go ahead and mark straight up that it is the Tinea Versicolor or Cutaneous Versicolor. What are those keywords? That is the hyperpigmented macules. Initially, yes, there would be macules, right? The hyperpigmented macules which become prominent on scratching, so there is the sign called as a scratch sign, yes, 𝗵𝗵𝗿𝗺 sign. Yes, in that what happens is the lesions would be very normal, but once we request the patient, okay, fine, could you scratch on this affected area, what happens is all the lesions becomes very pronounced. Yes, that is because of scratching. It irritates and the lesions become more pronounced. We can see them very clearly. So hypopigmented patches which gets darkened after the scratch, right? The answer would be the versicolor, right? Okay, fine. So now we're done with that part. As you can see in these images, right, these are the images of the groin area, and if I just zoom it in, yes, there is a very clear erythema, right? If we see, that is a Tinea Corporis, right? Okay, all right, and one of the very main reason could be poor personal hygiene, just reusing the underpants again and again could be one of the reason. Yes, because more or less these fungal infections are very prevalent, even though how much ever we keep ourselves clean, there could be, because a lot of these are normal commensals on the skin surface. Yes, if somebody is not having a good hygiene, it is a very huge indication that the person could end up having these infections. Okay, all right, So coming on to the next one, that is the Tinea unguum. Yes, this is a very interesting one. Yes, Tinea unguum also it goes by onychomycosis, right? Onychomycosis. So in this one, what's actually happening is there's this insult of the nail, right? But what are the exact findings do we see in these patients? The one of the very key one, right, would be yellow discoloration of the nail. Okay, yellow discoloration of the nail. Okay, one question. Okay, the next thing is going to be that fine, it will have subungual hyperkeratosis. Okay, in the whole of dermatology, right, this hyperkeratosis, subungual hyperkeratosis, where did we see? Yes, when we read about psoriasis, right, this was a type. Yes, in the nail psoriasis, yes, there was this hyperkeratosis point. Okay, so I hope you, in that video we went quite extensive about this topic, psoriasis. Yes, what is the actual problem? There is a hyperproliferation of the cells, and because of this we have parakeratosis. Okay, all right, so these are the 2 points, from the chapter psoriasis. Okay, so I hope you guys did well, and even in our video we went quite extensive about that. Okay, so there could be subungual hyperkeratosis. Okay, all right. And another thing that could be, we would see a thickening of nail plate, yes, and tunneling under the nails. Okay, now this next point, it is very interesting. Why it is very interesting is because of this one thing we discussed, that okay fine, we are seeing this hyperkeratosis thing, right? Okay fine, but we see in both of these two things. First is the topic of our discussion, that is the Tinea unguum, onychomycosis, and the other one, that is in psoriasis. So how would you differentiate that? Because the presentation is the same. So what is the key demarcation line that we would find that okay fine, this is yes and this is a no for that? Okay, first of all, we could do a KOH, right, and we could make a slide and we could make a preparation and we could just see it under the microscope. Yes, and one of it would have, we would see hyphae, right, fungal hyphae we would see, and in one, no, probably we would just see those parakeratotic cells. Yes, if we are lucky enough we would see it. Yes, okay, so the answer to this is the KOH would be negative in a psoriatic nail and it would be positive in Tinea unguum. So the KOH is positive in Tinea unguum. Okay, and how about the next one? Yes, the next one, what is it? Over here we have something called as pits. Yes, if you remember in psoriasis, we read that it has pits, and we also saw an image there. Okay, and the mnemonic, it goes by polish. Yes, and over there we read that the P was for pits. Okay, so in psoriasis we can see pits, and over here it is positive for this, and we have no pits. Okay, all right, so the next one is Tinea incognito. Yes, this is also very pretty interesting one. Tinea incognito, why? Because the reason it presents to us, because the patient is been using excessive of corticosteroid, the topical corticosteroid creams the patient has been using. Yes, but do you think this is the right treatment for the tinea infections? Definitely not. Yes, we would have to give the topical antifungal creams, yes, to treat the patient. And if the patient goes to a quack, they just write this cream and they have this abuse, right? So what's going to happen is the patient is going to have these symptoms, he's going to see the quack, and after that just they would be abusing this, right? So fine, the on the surface it would subside, but is it treating it? The answer is no. because of a very improper treatment, what's happening is we are having this new tinea infection called as tinea incognito. Alright, because of an improper treatment, yes, and the infection subside, yes, it would subside, yes, but once the treatment stops, the tinea would grow back and it would relapse, yes, as simple as that. Okay, alright, so it is because, first of all, it is because of this improper treatment and repeated use of steroids, yes. Topical steroids. Okay, and yes, the point we just discussed, that because of the improper treatment, the infection subsides, and once the treatment stops, there would be what? There would be relapse. Okay, all right, and a very classical finding in this, right? Because of the steroid creams, it is negative for KOH. It should be positive, but it is negative. Yes, and in the images, we can see that yes, it is not. We can see it is a very something which is not very aggressive. Yes, something which is happening over a course of time. Yes, it is not very acute presentation. Yes, the patient would give us a history of something which is going on for quite some weeks. Yes, and they would also may got the previous prescriptions if possible, or there would be some history of using the topical corticosteroids. Okay, in the next image as well, right, we can see over here, and in the image here as well. Okay, all right, so these are the three things. And what would you do for the treatment of these patients is, we would just give a very common thing, right? We would just start with antifungal creams, if required systemic, if not topical, and the infection would subside. Okay, all right, how about the next one, Tinea Corporis? Okay, so one of the main point is why there is this new category Tinea Corporis is why. The answer is because it is being used, right, only used when the areas which are not defined by tinea, if infections occur in those areas, we would say Tinea Corporis. Simple. You just go by this one thing and you will always have your concepts very clear. Tinea capitis, yes. Tinea unguum, yes. We have another tinea as well, yes. But if it is not specified, if the tinea happens on the trunk, yes, or probably on the back, these are not defined areas for tinea at that time, or if it is happening on the neck, these ones, what would we call them as? We would call them as Tinea Corporis. Okay, as simple as that. Okay, Tinea Corporis. So body except the defined ones. Okay, all right, and even in that, the most common one, right, these are the Tinea mentagrophytes. Okay, Tinea mentagrophytes. Okay, there is also one good table we discussed in our detailed series, right? What was it about? It was the most common organisms. Yes, the most common organism. All right, for tinea, what was it? It was the rubrum. Yes, overall it is Tinea rubrum except the one which are defined. Okay, all right, that is one point related to Tinea rubrum. Okay, but if it is Tinea corporis, we would just go for Tinea mentagrophytes. Okay, all right, that is one important thing. And I guess we all are very specialized in how to define an image. Yes, so how would you define? Yes, it is a very perfect circle. Yes, it is a circle, right? It is a disc shaped. Okay, and you see we have this crusting and clearing. Yes, so central clustering, peripheral clearing. Psoriasis, we never know, so we have to find it out, right? Okay, but this is a Tinea corporis. Okay, just because I am saying it, it is, but if this patient comes to us, yes, we should have two things in our mind. Okay, or but usually it is tinea because the lesions is very clear, very pronounced, right? This circle thing. Okay, all right. An addition, okay, to the initial part of this fungal cutaneous infections. Okay, so this is the cutaneous infections we did, that is the candida, right? So I want you to add this video after this right here. Okay, got it? So this video that is about Candida intertrigo will come after this. So we just got done with the first part of the cutaneous infections, right? That was the Candida, yes, and Candida albicans, yes. And now over here, yes, we have the second one, that is Candida intertrigo. So one of the 6 things, right? So today we just gonna discuss 2 of them. All right, so but there are total 6 type of Candida, yes, which we discussed in our detailed series. Okay, right here, intertrigo, yes, what is this? It is between the folds. Yeah, the word itself means it between the folds, right? So okay, so it is only a very specific well defined area, yes, between the folds. Right over here you can see in the axilla area under the breast, yes. So we can see this. How would you define this? Is it scaly? Yes or no? Is it scaly or no? It is not scaly, right? If you see here, it is not scaly. It is a very erythematous patches we are seeing. Okay, all right, it is non-scaly. So this is an erythematous, like with a red plaque. Okay, and even earlier we discussed about this thing, right? There are 2 types. There is white plaque and there is red plaque, and this is one of the red examples for the red plaque. Okay, all right. So inflammation of the body folds, that is the growing part, is one of it, and under the breast and the axilla. Okay, erythematous moist patches, yes, with whitish macerated patches as well. Okay, in these images that I have added, we cannot appreciate this part, we can only appreciate these. Okay, and one of the very key part is the last one, that is the satellite or the daughter satellites. Yes, over here we see, yes, it is very well pronounced, but over here we can also see these small patches, right? And in over here we have the main coalescing, the erythematous one, and over here we have these small satellite patches we see. Okay, that is for the Candida intertrigo. Yes, and how would you diagnose this? First point, yes, and what lab findings we could find. Yes, let us discuss about that. The investigations part is very interesting. Yes, what find we here, because there are spores involved in it. Okay, in the investigation, if we do a KVH preparations, we would find the spores and pseudohyphae, yes, for the Candida. Okay, and if there are spores and we give them a very particular environment, yes, the spores would grow. That is the finding we are having here. That is this, the germ tube, it would start growing. Yes, but at what temperature and what culture we have to give? That is the question. That human or sheep serum at 37 degrees for 3 hours, we could have this germ tube. We could visualize this germ tube. Okay, and this itself is called as a germ tube test, which is a screening test we use. Okay, all right, and in a wet KVH film we would find filamentous outgrowth. Okay, it is just an addition to that the previous point we just discussed. Okay, the next one, how would we treat it, is because it is a fungus, yes, we would give the antifungal, right? So we would give systemic ketoconazole, yes or no, right? We just discussed that ketoconazole, if we given systemically, it is hepatotoxic, so we would not use it. Okay, but yes, we can give topical, yes, but there are other oral antifungals that we could give. Yeah, and we would give antihistamines, because this is the patient would complain of pruritus, especially nighttime pruritus. Yes, moreover, the pruritus part is very prevalent throughout the day. Yes, but still pruritus is one of the thing because of the erythematous part you see. Okay, all right, so that is all about Candida intertrigo. All right, so that is all about the Tinea Corporis, right? So I hope you can define this image pretty clearly, Okay, Alright, so that is all for it. So I hope you had a great listen to this lecture regarding just the fungal infections, right? The cutaneous fungal infections. Alright, so thank you so much for listening.